Hi everyone, welcome back. Today, just like last time, we have a couple of topics that we're going to cover, and we're going to have a couple of questions and cases that we're going to cover as well. So we're going to start with the important topics. I want to cover a topic about autoimmune disorders. And of course, with most autoimmune disorders, if the disease reaches a severe level where the patient has a lot of symptoms and a lot of complications, especially big disorders like SLE, or scleroderma, or things that will cause disfigurement and complications, they will have to be put on steroids on very high levels. And of course, this will suppress the immunity and resolve the autoimmune disorder. Besides the infections, which are very common and very obvious, these patients will have infections, but we shouldn't really worry about the infections as much as we should worry about the cancers that these patients can develop. Of course, infections are prone to happen, and these patients can be treated with antibiotics if they develop infections. But the things that was really severe and that we should take very big consideration of is cancers. So if a patient has autoimmune disorder, for example, Sjögren disorder, Sjögren disease, and we start them on high dose of steroids, and later on the patient suddenly came back to the hospital developing with mild fever, with fatigue, with easy irritability, night sweats perhaps, these are telltale signs of infection, and this patient could be infected, and they could have symptoms of infection. However, if the antibiotics do not resolve these symptoms, we should have the cancer or malignancies in our mind as well. So malignancy and cancer are both very common and very plausible situations that are prone to happen in patients who are taking steroids or the patients who are immunocompromised. Of course, the cancer of choice that would always be the case in these patients is non-Hodgkin lymphoma. And it will present just like B symptoms. B symptoms basically refers to night sweat, vague pain all over, vague fatigue, mild fever, not very high. So all of these very vague symptoms, we call these symptoms B symptoms. So B symptoms are a sign of cancer in patients who are taking immunosuppression therapy. And the first thing that you should look for as a physician is enlargement of lymph nodes anywhere in the body. So just check the patient all over, look for any enlarged lymph nodes. If you find these enlarged lymph nodes, take a biopsy of them and send it to the lab to check whether or not the patient has lymphoma. And of course, if the patient does have lymphoma, you're going to have to use chemotherapy. And chemotherapy has way too many guidelines that I'm not going to cover right now. So that's the first topic, immunosuppression associated cancers. Any question? Okay. Another very important and very common topic, especially for orthopedic patients and young patients, is the fracture of a clavicle. In young patients and infants, this normally occurs by accident. If an adult is trying to pick up the infant by their hands or by their shoulders, they would maybe fracture the clavicle. But in adults, if the clavicle is fractured, it will cause a drop of the shoulder, and the patient will present, of course, with dropped shoulder, with a lot of pain, and with a nice history of how he broke his clavicle. So the things that you should worry about and check as a physician is, of course, the neurovascular status of the affected hand or the affected side. So if he broke his right clavicle, you should check the right hand and the right, basically checking the neurovascular status. So the neurons and the vessels. If these are fine, then everything is fine. You don't basically need to do anything except fixating the fracture itself. So the way that we check this is by checking the most distally. So we go by checking the hand by the fingertip. Basically, we press on the fingertip and we release, and this is called the capillary refill. So if you squeeze really hard on your fingertip and then you remove your finger, it will be yellow and then become right back again. This is called capillary refill. This should be less than 2 seconds. If it was more than 2 seconds, this means that the blood supply to the finger is inhibited or just basically diminished. So you should go back up and then check the radial pulse. If there's also no pulse here, you should go up and check the brachial pulse, and so on and so forth. So basically we start most distally and then we go proximally. Same thing with the neural status. We go by checking the finger web of the hand, then we go by checking the palm of the hand, and we keep going for basically proximally until we find to which extent the disease spreads. Not the disease, but mainly the symptoms reach. So this is how we check the neurovascular status of the affected side of the broken clavicle, because the clavicle is very close to the brachial plexus, and the broken clavicle can injure the brachial plexus, especially the brachial artery and the subclavian artery. If these are injured, the patient will definitely have symptoms in their hand. So that's the easiest way to check of complications with the broken clavicle, which is very common. So if you don't find any neurovascular symptoms whatsoever, you simply fixate the clavicle as much as you can by basically looking at it and fixing it, and then putting the patient in a position, or we use a string that is an 8-figure, and we call this the 8-figure string. So basically the patient wears it from behind, and it basically stretches his shoulder backwards, and this will keep the clavicle as fixed and as reduced as possible. And of course, if there is any neurovascular symptoms, you should basically take the patient to surgery right away. If there is severe symptoms, I should say. If there is mild symptoms, like very mild numbness in the hands, or very mild reduced capillary refill, or very mild affected artery, in this case, we don't really do surgery right away. Instead, we do the CTA, which is CT scan with arteriograph. This will tell us exactly how much the arteries and nerves are damaged. And based on that details, we will see whether or not to take the patient to surgery, because basically weighing out the risks and benefits, right? So that's for broken clavicle. Any questions? Okay. All right. So another also very common topic, especially in pediatric, is ulcers or small papules around the mouth or inside the mouth. This is very common in the exam. I cannot stress enough how common this really is in the exam. So basically, we'll give a scenario, a long scenario, and the important detail is that they have a small papules that are appearing in the front of the mouth or in the back of the mouth, and that's the main detail, the main differentiating detail for the whole case. So herp angina, which is caused by Coxsackie virus. That's the first scenario that you're gonna have to focus on. The second scenario is gingival stomatitis, which is caused by HSV, which is herpes virus. So herp angina is caused by Coxsackie, and gingival stomatitis is caused by herpes. It's kind of confusing, but once you memorize them, you're basically gonna be good for life. So herp angina, which is caused by Coxsackie virus, like we said, occurs posteriorly in the mouth. So basically in the soft palate and behind. And you don't really it's supportive therapy, you shouldn't really do anything about it. Sometimes they're gonna be generous in the question, and they're gonna tell you that the patient also have spots on their hands and feet. And this is also a telltale sign of Coxsackie infection. Coxsackie virus normally causes what we call the hand, foot, mouth syndrome, or foot, mouth, hand syndrome, whatever arrangement you feel most comfortable with. So Coxsackie virus causes the papules in the hands, in the foot, and in the posterior of the mouth. So this is called the hand, foot, mouth syndrome. It's associated with Coxsackie virus, and it's called herp angina. It's very important. The anterior side, if the papules occur only in the anterior of the mouth, say around the lips, maybe around the tongue, around the teeth, so in the anterior to the hard palate, this is herpes virus, and the treatment is simply acyclovir. Sometimes, actually, herpes very commonly occurs outside the mouth, so mainly around the lips, and this is very common and very known. So it makes sense that the infection might spread just a little bit backwards to inside the mouth, but it's not going to go all the way back. While on the other hand, Coxsackie is a global infection, it's all over. So it makes sense that we'll go to the hands, to the feet, and it's going to go deep into the mouth, to the posterior of the mouth. That's how I remember it. Coxsackie is all over, so it goes to the behind. Herpes is mainly around the lips, so it makes sense that it's going to go just a little bit behind. So we have herp angina and Coxsackie virus, and we have gingival stomatitis with herpes infection. And these are the ulcers and nodules that you need to know around the mouth, which is very common. Okay, Coxsackie is treated supportively. Herpes, we treat it with acyclovir. Any questions? Okay. This topic is also kind of important. So often in the exam, you will see that the patient has motion tenderness when doing the pap smear or when doing a cervical test, especially in gynecology cases. So when the exam says that the patient has motion tenderness, which means that when the physician is basically rubbing the brush around the cervix, the patient feels very painful or very painful sensation around the uterus area. And this indicates one of two things. It's either that there is an inflammation, and that's why there is pain when they remove the cervix, or there is a PI or endometriosis, right? So it's either endometriosis or there is an inflammation. And it makes sense, an inflammation, because when an infected area or inflamed area, whenever you move it or rub it or press on it, there will definitely be pain, of course. So an inflammation such as pelvic inflammatory disease, which is very common in the exam, you're going to have pain whenever the basically cervix is moved, especially with the pap smear or where there's any test that basically moves the cervix. The other scenario is the endometriosis. Endometriosis basically causes, especially if it's invasive, it will cause fibers that fixate the uterus around its place, so the uterus will not be very mobile as it should be. So whenever you move the cervix, you're basically going to be pulling the uterus or moving, manipulating the uterus. So this also causes pain. Of course, there are some signs that would favor either of these cases. For example, in PID, in the inflammatory case, you're going to have fever, and endometriosis, you're going to have cyclic pain and cyclic bleeding. So, these are some cases that would go for either case. But in general, the motion tenderness is associated with PID and with endometriosis. Of course, the exam is never going to tell you, it's not going to be this easy. They're not going to tell you the patient has motion tenderness, what is the diagnosis? It's not going to be like that. It's basically going to tell you a long history of a patient who is having infertility and she's having pain every now and then. She took some antibiotics, they didn't help, but then she went to see an infertility clinic, didn't help at all. Then we did we did a pap smear and we found the patient had motion tenderness, and then going to keep talking whatever. And then there's going to be endometriosis or PID. But they're going to ask you about the treatment of one of these cases, for example. Of course, endometriosis is treated by, you're going to use oral contraceptive pills, and if that doesn't treat it, you're going to have to do hysterectomy eventually. For PID, basically you're going to use antibiotics. And for PID, actually, speaking of, PID have to be treated very thoroughly and aggressively. So just go all in with antibiotics. Because if you don't treat PID very well, the patient will definitely develop adhesions. And adhesions will cause infertility, and they will cause ectopic pregnancy, will cause so many problems for the patient. So for PID, just go all in with antibiotics. Okay? All right, so next topic is the afterload, the preload, the cardiac output for shock syndromes, or basically the shocks that you can see in the exam. Whenever they say that the patient has a shock, and they can ask you about which of the following is the type of shock the patient is experiencing. That's the first possibility. Or they can ask you about what's the affected preload, afterload, or cardiac output. This is very common. They like to ask about, basically they can tell you a scenario, and they give you 3 figures or 3 variables. And the first option is increase, increase, decrease, 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 increase, stay the same, whatever. They love asking about this for some reason, and it's really frustrating sometimes. But it's fairly simple. I mean, in shock, basically, whenever we say shock, we probably most of the time we mean one of 3 things: either cardiac shock, either fistula-associated shock, or hypovolemia. Of course, there are some other shocks like I think neurogenic shock, there is burn-related shock, whatever. But these are the main ones that you can have to know for the exam. So the cardiac shock is basically acute cardiac failure. Anything that would damage the heart, think myocardial infarction, think infections, think clots, whatever. So anything that would damage the heart can cause cardiac shock. And in cardiac shock, basically, so first we're going to have to know what are the 3 variables that we're going to talk about. So the cardiac output is whenever the heart contracts, how much blood is pumped out of the heart. That's the cardiac output. The second variable is the preload. Preload refers to the amount of blood that reaches the heart with every heartbeat. So how much blood comes to the heart. Afterload refers to the amount of blood that the heart has to the amount of force that the heart has to exert to push the blood out. So afterload is determined by the aorta, of course, and by the aortic valve, because the narrower the valve, the more the blood has to push, the heart has to push. And preload refers to the amount of blood that's coming to the heart. Cardiac output refers to the cardiac contractility. So in cardiac shock, of course, the heart is damaged, so the cardiac output, the cardiac contractility will decrease, of course. And the cardiac, basically the whole blood in the system is going to be stagnated, and it's not going to move around. So this will increase both afterload and preload, because the blood is basically not moving anywhere. So in cardiac shock, we have increased preload, afterload, and decreased cardiac output. There's another scenario that is very, very interesting, honestly. Okay, so we know that the arteries are very strong and very tensile. They're basically stretchy. Not as much real as veins, but they have some stretching capabilities, but they're also very elastic, which means that as soon as you push them, they will contract back, and this gives the arteries very high blood pressure. That's why we have 120/80 whenever we measure blood pressure. 120 is the arterial. This is what gives us the blood pressure, the very high blood pressure. In contrast, the venous blood pressure is always around 10. So 180 and compare that to 10. So venous almost have no blood pressure whatsoever. Sometimes it's even zero. So because the veins basically don't have anything pushing the blood in them. The heart is pushing into the arteries, and that's why the arteries have very high blood pressure. But the veins are basically the blood being, I want to say pushed, but it's mainly dragged from the arteries into the veins. Because as soon as you use the capillaries that connect the arteries and veins, the blood reaches a full stop and then it's just being moved as the new blood comes in. So the blood pressure in the veins is very, very limited. It's about 10 or even less. But the arteries have very high blood pressure. So the heart has to exert a lot of force to push all this blood into these already constricted, already filled arteries. And this basically causes the heart to exert a lot of power. In cases of fistula, where we have a major artery that is directly connected into a major vein, this basically creates a bridge between the arteries and vein. So whenever the heart pushes, it's going to push a lot of blood into the arteries, but all of this blood with all this great pressure will escape into the veins because the veins has basically no pressure to basically create an equilibrium. So the veins will now have very high blood pressure because all of this strong and fast blood will go from the arteries into the veins. And of course, the arteries, as a result, will decrease their blood pressure as well. And the heart will have less work. And so, in cases of fistula, this will cause, of course, again, the heart will try to maintain the high blood pressure for the arteries because that blood pressure is necessary for the oxygen to reach all of the organs, basically. So, to compensate, the heart will contract harder and stronger to maintain the 120/80. But it's never going to do that. It's never going to be able to reach the 120/80 as long as there is the fistula connecting the arteries with the veins. So the heart basically eventually reaches a failure status. And we call this high output heart failure. Basically, heart failure due to the extreme amount of strength that the heart has to keep contracting to maintain the 120/80. And this is the result of a fistula between an artery and a vein. And in this case, the shock that is caused by a fistula is called high output heart failure shock. And in this case, of course, they're going to have high cardiac output because the heart is contracting more, and we're going to have high preload. The blood that is going to the heart is going to increase because now we have a direct source that is going to the veins. Instead of the blood being pushed, we're going to have a direct source, so the preload will increase, the afterload will decrease. The hypovolemia is very fair and very simple. So whenever you have less blood, the heart will contract less because it doesn't have as much blood to push away, and the preload will decrease, the afterload. The afterload will increase, interestingly, because the vessels, the small vessels in the hand and the fingers and the feet and the basically skin will contract to maintain high blood pressure internally and in the brain to basically save the vital organs, and that are much more important than the hand and fingers, I guess. Okay, so these are the shock syndromes. Okay. So there was this one point that I found interesting, which is, do you give sildenafil or Viagra pills to patients who have cardiac stents, who have had stents placement? This question came in my exam, and so basically a patient came in with a cardiac stent who was, I don't know, 50 or something years old, and they had three stents in their heart, and they wanted to take sildenafil or Viagra pills. Do you give them these pills or not? That was mainly the whole point of the question. And the answer was yes, you do. You do give them stents, you do give them sildenafil, but with caution. So sildenafil does exert a lot of work in the heart, but not as much as you would really expect clinically. So we do prescribe sildenafil for patients who are having even cardiac infarction sometimes. But you have to be just kind of careful in the amount that you give the patients. The things that are absolute contraindication. So basically, sildenafil is a relative contraindication, not real and absolute contraindication. The absolute contraindication for patients with any cardiac abnormality is alpha blockers. Alpha blockers will exert enormous effort in the heart. So the patients who are having any cardiac abnormality or even mild rhythm abnormalities should not take alpha blockers. Alpha blockers are the medications ending with the suffix sin, S-I-N. Okay. So these are the topics that I wanted to cover before we go to the questions. Actually, I have some more questions here. So I have quizzes and I have question or cases. Let's start with the quizzes first. Just a couple of quizzes that I post on the Patreon page, but nobody read them, so I'm just gonna have them here. So the first quiz is: a patient is being treated with Giardia infection, should avoid which of the following? So Giardia infection in the stomach, which is a protozoa, or in the GI tract, which of the following should be avoided by these patients? Beans, coffee, alcohol, or nuts? Okay, I'm gonna give you a second to guess which of the following is the right answer. So again, protozoa Giardia infection in the gut, and these patients are being treated right now. Which of the following should they avoid? Beans, coffee, alcohol, or nuts? Exactly. Yeah, that's correct. Patients being treated with Giardia infection, they take metronidazole to resolve Giardia infection. And of course, as we know, metronidazole causes diacetyl-like reaction. So whenever the patient drinks alcohol, when they're taking metronidazole, which is very common in the clinical practice, very often patients will drink alcohol while they're taking metronidazole. And this will cause severe vomiting, nauseousness, and sometimes coma, and even worse. So patients who are taking metronidazole, regardless of the original infection, we don't care about the infection, we care about the treatment. So metronidazole is contraindicated with alcohol. And these patients who are treated with Giardia infection, for which we use metronidazole, should not drink alcohol. Okay. All right. So malignant thyroid nodules are characterized by either homogeneity or hypoechogenicity, or well-defined borders, or absence of calcifications. So which one do you think is the answer? Basically asking which of the following is the malignant feature of thyroid nodules. The malignant features is basically anything. So think of cancer cells that are combined together to form a nodule. So whatever is going to cause these cells to be very active is, of course, a malignancy. We want these cells to be as dormant as possible. Dormant, so basically not moving, not doing anything at all, just staying in the place, minding their own business. And the things that would cause them to do this will cause them to be roundish. They'll have a lot of fluid. They will not going to have calcification. So calcification, of course, indicates an active replication process. So calcification is malignant. Whenever the borders are not roundish, so basically with spikes and irregularities, this indicates that the cancer cells are moving outside, trying to reach further and further. So this is also a sign of malignancy. And basically any dead tissue inside that would appear as basically more dense and less dense areas, this would give us tell us a sign that this cancer is multiplying so fast that some areas are dying and other areas are being generated very quickly. So we call this heterogeneity. Heterogeneity is a sign of cancer as well, so a sign of malignancy. So basically, malignant features include ill-defined margins, irregular shapes, hypoechogenicity, heterogeneity, absence of cystic lesions. Cystic lesions is basically saying that there's a lot of fluid inside. Whenever there's a fluid, that's a good sign that this is not cancer. And absence of calcification. Okay. Of course, invasion is a sign of malignancy as well. All right. So the medication that treats nocardia infection works by inhibiting the synthesis of cell wall, inhibiting the cross-linking of cell wall, inhibiting folate synthesis, or inhibiting protein synthesis. So basically asking you what is the mechanism of action of the medication that treats nocardia. Okay, any thoughts? Okay, So there's this great mnemonic that for nocardia and actinomyces, these two infections are just like always together. The mnemonic is SNAP, S-N-A-P. So S for sulfonamide, N for nocardia. So we treat nocardia with sulfonamide. A for actinomyces, P for penicillin. So we treat actinomyces with penicillin. So SNAP, S sulfonamide, N nocardia, A actinomyces, P penicillin. Nocardia with sulfonamide. Sulfonamide is a folate synthesis inhibitor, along with dapsone and trimethoprim. So these are the only three folate synthesis inhibitors that you need to know for the exam. Okay. One more quiz. So a patient developed difficulty hearing after being treated for severe abdominal infection. What is the medication used? Vancomycin, neomycin, furosemide, chloramphenicol. This is a very nice question. So, which of the following antibiotics caused this patient to have severe difficulty hearing after being treated with severe abdominal infection? Vancomycin, neomycin, furosemide, and chloramphenicol. Any thoughts? Okay, so abdominal infections, especially severe infections, are treated with aminoglycosides. Matter of fact, this is one of the few cases in which we jump to aminoglycosides first. So aminoglycosides, of course, include neomycin. So neomycin and aminoglycoside, the whole class, can cause ototoxicity, which is basically deafness in the ear, which is unfortunately irreversible. The question did throw a distractor in there, which is furosemide. Furosemide also causes deafness, which is irreversible. But we don't use it to treat abdominal infections. We use it to treat abdominal distension, not infections. Whenever the patient has a lot of fluid and ascites in the abdomen, we can use furosemide to relieve this amount of fluid. So ototoxicity or difficulty hearing is present. I need to stop hitting the desk. So difficulty hearing is caused by aminoglycosides and loop diuretics, which include furosemide. Okay, so that's for the quizzes, and now let's go for the cases. So, our first case, a 2-month-old newborn is being evaluated for developmental dysplasia of the hip. The physician performed an ortolani maneuver and felt a palpable clunk. In order to confirm the diagnosis, which of the following is the most appropriate? Do we use a hip ultrasound, or a hip X-ray, or a pan CT, or a pan MRI? Okay, so first, let me just repeat this scenario one more time. 2-month-old newborn being evaluated for DDH, developmental dysplasia of the hip. The physician performed the ortolani maneuver and it was positive, so it's definitely DDH, but we want to confirm it. So which of the following do we use to confirm the case? Hip ultrasound, hip X-ray, MRI, or CTA? Of course, this depends on the patient's age. I think it was 4 months old, the cutoff point. Yeah, I think it's 4 months old. So basically, whenever we suspect DDH, which is very common in pediatric, the physician has to first try to figure out whether or not the patient actually has DDH. So we use the ortolani maneuver, and if the ortolani, basically holding both of the newborn's legs and pushing them forward, and then laterally. And if you hear a clunk or a popping sound, basically, this indicates that the patient has DDH, or very high possibility of DDH. So in this case, you should do a hip ultrasound if the patient was less than 4 months old. And if it was older than 4 months old, we should do hip X-ray. This will tell us whether or not the patient has DDH. Basically, in patients who are less than 4 months old, their hip the whole skeleton system is not really calcified enough to show the densities and to show the defining markers and marks for DDH. So for young patients, we use ultrasound, because the ultrasound can tell you their bone is basically soft enough that ultrasound can pierce through it and tell us the valuable information that we need to know. But older than 4 months old, their bone is calcified enough for us to see their bone structures. So basically, if you suspect DDH, perform the ortolani maneuver, and if you still suspect DDH, then do ultrasound or X-ray depending on the patient's age. 4 months old is the cutoff point. Okay, any questions? All right, so this case says a homeless patient came to the clinic complaining of skin lesions all over his body. These lesions are small and purple. They can be found all over. Picture of the lesion is associated in the exhibit. 2 weeks prior to this visit, the patient was given sulfamethoxazole for pneumocystis jirovecii. So the patient clearly has an immunosuppression scenario, and homeless patients normally or commonly in the exam have HIV. And in this patient, it's advanced HIV enough that he was given antibiotic for an HIV-associated infection. So the patient definitely has HIV. We can conclude that much. The question asks, where else do you expect to see these skin lesions, these small red purplish skin lesions? Do we expect to see them in the cornea and retina? Do we expect to see them in the small intestine or the brain or underneath the nail beds in the nails? So let's just revise the key features once more. Homeless patient with advanced HIV came with reddish, small or purplish skin lesions all over his body, and he was treated recently for an HIV-associated infection. Basically, the question asks, where else should we find these small lesions outside the skin, basically? Other than the skin, where else should we see these lesions? So, any thoughts? Okay. So basically, of course, this is Kaposi sarcoma. Kaposi sarcoma is associated with two conditions, advanced HIV or herpes type 7 and 8, I think. Yeah, so other 6, 7, 7, and 8. So these two conditions are associated with the Kaposi sarcoma. And Kaposi sarcoma commonly occurs in 3 main locations. So in the skin, of course, which is the most obvious, and this is the main thing that drives the patients to come to the clinic. The second place that they are commonly occurring in is the GI tract and the respiratory system. So these are the 2 places other than the skin that we can see Kaposi sarcoma, and indeed we do have small intestine, one of the options. Okay, so homeless patient, diarrhea, we went through all these notes. Okay, I think we'll do 2 more, just have some time. So, a 62-year-old female patient came to the clinic complaining of easy fatigue. Her symptoms started a few months prior without any preceding incident. The physician asked the patient to read from a newspaper, and she developed ptosis and diplopia within minutes. Her aunt was recently diagnosed with SLE. Which of the following should be screened next? Lung cancer, SLE, thymoma, myopia. So, she's a young female patient, 26 years old, and she's complaining of easy fatigue, and her symptoms started without any incident, without any preceding trauma or any event that she recalls. She was reading from a newspaper, and she quickly developed fatigue in her eyes, so much that her eyelids came down and her eyes became diplopic. And her aunt was recently diagnosed with SLE. So do we screen the patient for SLE or for lung cancer or for thymoma or myopia? Of course, this will strike some people just like, oh, this is that or this very quickly. This is, of course, myasthenia gravis. The diagnosis is very common in young female patients around this age, 26 years old or so. And the SLE thing is just a distractor that will commonly be thrown in the question. The hallmark for myasthenia gravis is one of 2 things. Either the patient basically develops ptosis whenever they read, or diplopia whenever they read. That's the first thing. And the second thing is dysphagia. Whenever they try to eat food, they will feel fatigued in their mouth very quickly, and they cannot chew anymore, or that they cannot swallow food anymore. The main issue in myasthenia gravis is the attack against the presynaptic acetylcholine receptors. So basically, our bodies cannot maintain contraction of certain muscles for long times. The initial contraction is fine with full strength. The patient can contract their muscles fully, no problem, but they cannot sustain that contraction for long times. So whenever you tell them to read, their eyelids has to be up for the whole time that they're reading, and their irises, the whole eye muscles have to be contracting just right enough so that they can read the newspaper without any issues. But they cannot maintain that contraction for a long time. That's why they feel diplopia and the eyelids begin to go down. The same thing with dysphagia and chewing. Chewing, of course, because you're going to be chewing and moving the muscles for the mastication muscles a lot, and that's not going to be possible with myasthenia gravis. The same thing goes with swallowing. The peristalsis of the esophagus cannot maintain long peristalsis for long meals, basically. And patients with myasthenia gravis should be screened with thymoma, of course. Thymic disorders and thymic tumors are very commonly associated with myasthenia gravis. Why they're associated is not clear. However, sometimes patients who are having thymoma or thymic disorders and they're also having myasthenia gravis, once we do thymectomy, their myasthenia symptoms completely resolve for some reason. So there is a link, although it's not very well understood. Okay. Yeah, there is another test that we can do to basically screen or confirm that the patient, whether or not this patient has myasthenia gravis. We do give them a medication called prednistigmine. No, not prednistigmine. I think it was. I forgot what it was. But basically, we treat them with prednistigmine. So this replenishes the acetylcholine that is being destroyed, or the receptors that are being blocked. So we basically increase the amount of acetylcholine, increasing the chances that these receptors will be activated. So we treat myasthenia gravis with prednistigmine. I think it was industigmine. Yeah, industigmine, exactly. So the medication that we use to diagnose these patients is industigmine. If industigmine resolves all symptoms completely within a couple of seconds, and the patient has no symptoms for a couple of minutes, this confirms the diagnosis of myasthenia gravis. In other words, if the patient is reading a newspaper and then they develop diplopia and ptosis, this is very suspicious of myasthenia gravis. We can give the patient industigmine, and if industigmine resolves the symptoms completely, and then they can open their eyes and continue reading like they had nothing at all, and this develops within seconds, then this is very suspicious with myasthenia gravis, and this is likely the confirmative case. And that's how we confirm myasthenia gravis. But we don't do this anymore, honestly. We just go directly for the antibodies nowadays. But this is a test that you might likely see in the exam. So industigmine resolves the symptoms of myasthenia gravis momentarily, and we can use this to diagnose the patient. Pyridostigmine is what we use to treat myasthenia gravis altogether. Okay, one more case. So, a prisoner complains of shortness of breath and mild cough for 2 weeks. A prisoner is in prison cell. His symptoms have been persistent and non-progressive. His cellmate is also complaining of the same symptoms. PPD test showed 4 centimeters in duration after 24 hours. Chest X-ray shows diffuse infiltration across both lungs, and the patient insisted that his symptoms are mild and non-disturbing to his life. Which of the following is the best next step? Do we give the patient isoniazid, or azithromycin, or linezolid, or amphotericin B? Okay, so let me say this again. Basically, a prisoner in a prison cell with his cellmate, and this prisoner is having pneumonia symptoms, but the pneumonia symptoms are very mild, not affecting his lifestyle. The treating physician at that hospital or that prison obviously suspected TB, so they did the PPD test and it showed 4 centimeters in duration, and the chest X-ray showed diffuse infiltration all over his lungs. And it's asking you about the treatment. What do you use to treat this patient? So this should jump right at you that this is a case of TB, of course, because TB is very, very common in prison. But the physician already performed PPD and was 4 centimeters indurated. If you remember that PPD, basically the skin test for TB, the induration or the increased area after you inject 24 hours after the injection of PPD should be at least 15 millimeters to confirm the diagnosis of basically TB. Yeah. So that's in healthy patients, and patients with immune compromised, 5 millimeters in duration will give you the diagnosis. However, regardless of the PPD test, which is negative in this case, chest X-ray showed diffuse infiltration in both lungs. This is inconsistent with TB. So these 2 clues here that would exclude TB, which is very common in prison and should be the first thing that you should think of. So what is the next most common thing that occurs in prison? Of course, walking pneumonia is common. Walking pneumonia is common among 2 or 3 places. mainly prison, soldiers, ironically, and college campus, and basically house schools. So any place that there's a lot of gathering of people that keep gathering to the same place will have high risk of mycoplasma pneumonia or walking pneumonia. Basically, mycoplasma pneumonia, walking pneumonia is caused by mycoplasma pneumonia. They are the same thing. So this infection infects both lungs, and it shows as diffuse infiltrates all across both lungs. And these patients will have pretty much no symptoms whatsoever, because the infection is not in the alveoli itself. So this is the alveoli that the air goes in and the diffusion occurs and the air leaves. But the infection doesn't occur here in the alveoli, so it doesn't block the airway. It occurs behind the alveoli. So that's why these patients are not complaining of any symptoms. And that's why it's called walking pneumonia. Because when you do the chest x-ray, you will see a drastic nightmare. You will see infiltrations all over across both lungs because there's a lot of these cells, a lot of these basically mycoplasma. However, the patient is not complaining of anything because the air can go in and out easily. And they might have just mild fever. And the infection is and the patient basically is going to be walking while they're having this pneumonia, this severe looking pneumonia chest x-ray picture. But they're going to be just walking just fine. That's why it's called walking pneumonia. And it's very common associated with, like we said, prison, campus, and soldiers. So mycoplasma pneumonia is actually so mild, like it's barely causing any symptoms. But it's also so mild that pretty much any antibiotic can resolve the infection. And sometimes the patient is taking antibiotic, for example, for urinary tract infection, and as a coincidence, it will also treat the cough that the patient had for the past 3 or 4 weeks that he didn't know what was the cause of that cough. And when he took the antibiotic for whatever else that he took it for, it will also treat the mycoplasma pneumonia. But the treatment of choice, if you've given multiple choices, we go for azithromycin because the patient has only to take the pills 3 times, so only 3 pills of azithromycin will resolve the infection completely. Sometimes we go for 7 days treatment just to be perfectly sure, especially in these cases because the patient is in a prison cell. So it's very common that he will infect others very quickly if he's not treated very effectively. So mycoplasma pneumonia causes walking pneumonia and is treated by pretty much anything, but we go for azithromycin. The hallmark for mycoplasma pneumonia is chest x-ray finding that are very severe, but the patient is walking just fine. All right. I think I'll end it here. Okay, we can do more. Okay, no, let's just leave that for next time. So it's been 40 minutes. I think I'll end it here and hope you guys learned something. And I'll see you guys later.